Hi, everyone. And thanks for dialing in for this call-in at 3 o'clock. Can I ask the participants who is in the gallery to mute themselves first? So this timestamp, this is a APSC CME webinar series on the 9th of July for a bifurcation workshop, focusing on Culotte technique. Our target audience are interventional cardiologists in training, and want to make this workshop concise for the learning cardiologists. The workshop is held in Sengkang General Hospital, a new and latest general hospital in Singapore, in the northern eastern part of Singapore. And this is my team during this period of COVID-19, my heart center, National Heart Center staff at Sengkang CBM. Just a quick announcement, APSC JCS has a 2020 webinar hosting from 27 July to 1st August. And the registration is now open. And this is a virtual webinar recognizing the fact this year our APSC Congress has been postponed. This webinar is brought to you by APSC. This session is endorsed by the Singapore Cardiac Society PCI chapter, supported by Sengkang General Hospital in collaboration with Terimo. These are our chairs, moderators, operators, coordinator, and panelists, which I'll give a brief introduction to. So a little bit about myself. My name is Jack. I'm an interventional cardiologist at the National Heart Center, Singapore. Currently the president of the Asian Pacific Society of Cardiology. And recognizing the fact that we still need continuous education, it's too bad we can't work together face to face, but this is for the time being what we can do. With me as my co-moderator is Datuk Dr. Rosli Muhammad Ali, my good friend and a very knowledgeable and a great teacher. He taught me a lot of stuff as well, over and beyond cardiology and interventional cardiology. So he's going to share with us as my co-moderator his tips and tricks of doing Culotte intervention. These are my operators. We have my boss, Dr. Aaron Wong, who is the head of cardiology at Heart Center. Chi Yang, who's going to assist him and teach us a little bit more about IVUS imaging. Dr. Wong Ling Yen is going to help us at the wet lab bench model that Terumo has kindly provided. Dr. Takashi Kajiya from Japan, who is also going to demonstrate for us as an operator on the wet lab, showing us what not to do for Culotte stenting. Our coordinator for today is Dr. Ke Yen San. And these are my esteemed panelists, Dr. Fahim from Tan Tock Seng General Hospital, Dr. Sydney Low from Australia, Dr. Pham from Singapore, Dr. Fazila from Bangladesh, and Professor Joshua Win from Myanmar. A little bit of disclaimer, the content is copyrighted by APSC. Please don't distribute it without prior permission. If you ask me, I'll ask you just distribute it, but please ask me. The views and opinions expressed in the webinar are those of the faculty and do not necessarily represent those of APSC. A little bit of housekeeping. This session is live streamed and recorded and will be made available by Rutherford Medicine Live, APSC Facebook Live, and YouTube page live. For the Singapore registered physicians, CME points will be awarded to you. If you do stay on for at least 1 hour, we'll submit your CME points directly to SMC. You will receive, for the rest, your certificate of attendance upon completing a survey sent by email after the webinar. So for those who are not in the gallery, we have about 600 participants who are registered. You can submit your Q&A through this button, and we'll try to answer live or off camera later on. The learning objective today, we want to go through step by step to learn the Culotte technique in bifurcation stenting targeted at interventional fellows. We want to show you what is the correct patient to choose for a Culotte technique. We want to avoid pitfalls in Culotte stenting, and also a little bit into understanding how imaging can be used and applied for bifurcation stenting. I also want to thank the nomination from the cardiac societies, nominating this very good fellows that had a competing entry. So these fellows will be participating with us on camera in a gallery, and they will represent the rest of the participating fellows who can't get a chance to ask the correct questions. So I'll expect this bunch of fellows to ask the most appropriate questions so we can have a very fruitful session. We'll make sure that all the questions asked by this group of fellows are answered live. Hopefully they will be representative of all the questions that's asked by the participants as well. So thank you very much. Remember to register for APSC JCS. Without further ado, I'm going to stop my screen share and ask my co-moderator, Dr. Rosli Muhammad Ali, to share with us his tips and tricks on Culotte stenting. Rosli, please.
Jack, thank you very much for the kind introduction, and I'm just pleased to know that that you are organizing this session. I wonder whether you can see my slideshow. Okay, share screen. All right. Are you seeing my slides at all?
Not. Is anyone else seeing something? I don't see.
Yep, I'm seeing it.
Yeah, I think you should be seeing it now. So you're talking about Culotte stenting. You know, when we think about bifurcation lesion, the first thing that comes to our mind is whether we should use a 1 or 2 stent strategy. Obviously, if it's not a true bifurcation, or somewhat even in a true bifurcation, sometimes you can get away with just provisional stenting. But when you look at true bifurcation lesion, then and the side branch is a large side branch, and it involves more than 5 mm of the side branch lesion, and that area or that side branch supplies a large burden on myocardium, then one needs to consider 2 stent strategy, with the aim of, number 1, that you must not miss the ostium, and secondly, that when you put in a 2 stent strategy, the stents must be well expanded. Now, there are a couple of stent strategy that can be considered in various subset of lesions, but we are just going to concentrate on Culotte stenting. This is the ideal anatomy for Culotte stenting. Obviously, it has to be a true bifurcation lesion, 011 or 111. The proximal mean vessel is large, but what is important is that the size of the distal mean vessel and also the side branch are almost close in terms of diameter size. And ideally, it should be a shallow angle whereby the gradient, or rather the angle between the side branch and main vessel should be less than 70, or in certain instances, less than 75 degrees. Now, I just want to share with you a case. In fact, this is not a case, my own case, but it's good because it's, we can graphically show it. And you can see clearly that this is a 111 lesion affecting the proximal diagonal, proximal LED, and the first diagonal branch. And the diagonal branch, you can see it's slightly smaller than the distal mean vessel, but quite a good in terms of sizing. So this, the question first comes is a brush stem. So you must remember that it has to be some amount of distance from the side branch so that you will end with as Culotte stenting. So once you have placed the stent there, then and dilate and deploy the stent, remember to do a pot, because if you don't do a pot and you try to wire across the stent struts into the main vessel, you might sometimes inadvertently go out from the stent struts. So I remember years ago, 10 years ago, that's what happened to me. So remember, pot first, and then you can wire the diagonal branch, in this case, into the main vessel. So a flip-flop of wires is safer. So once you have done that, you removed, once you wire it into the main vessel, then the LED, you pull out the wire and then pull out the jail wire and then get it in. You can actually do not have to wire it inside the side branch. Some people may do that, but you don't really have to, because you don't require any more wiring at that point in time. Now, you then dilate the stent struts towards the main vessel. Now, the question is, what is the balloon size? At least a diameter of 2.0, if not larger, because you need that amount of balloon dilatation to allow the stent to go across. In this case, it's quite safe. You are going to use a 2.5 balloon to dilate the stent struts. Once you have done that, and this is results after, so you can see that results, the LED, at least in this case, is quite well prepared from the initial balloon dilatation. Then you put in the stent, and the stent should be sized according to the main vessel in the distal, and preferably you end the stent slightly more proximal than the stents that you place in the side branch. And this is to ensure that you can get a well expanded stent, especially if you are using a slightly bigger stent than the side branch stent. So once you have done that, you deploy the stent. And once after deploying the stent, you remember again to pot the proximal vessel to ensure that there's good stent expansion in the proximal main vessel. Once you have done that, then you recross through the stent struts into the side branch and wire into the left main, into the main vessel. And you have to end any two stent strategy with kissing. So you should have a two-step balloon inflation, and this can be just balloon dilatation. And it's preferable that you should go in with a non-compliant balloon with high pressure to ensure stent good stent position, and then you end with kissing. Once you have done with kissing, then you should be thinking about a final pot if that is necessary. Remember always to try to deflate the balloon simultaneously at the same time, because sometimes you deflate one after the other, you can have some distortion of the stent struts. So you want to avoid that from occurring. So the final pot is preferable to be done, especially if you have an imaging, then that would be good. But if you are not going to have an imaging assessment, then the final pot is quite crucial in a sense. And this is the final results that was shown. So a pleasing results in the end for the LED diagonal. Now, one of the other things to consider when you put in the stent, especially when you put into a large vessel, like the left main stem, would be the ideal stent for culotte stenting. Obviously, one has to use the current generation stents. For large vessels, you need to have large cells that will be able to expand very well. You also need to know the expansion capability of each stents that is available right now with regards to the stent size and also with regards to the vessel size.
Okay.
And good recrossability is one of the key things to have in ideal stent, because that will make your procedure so much safer. So these are some of the DS designs over expansion. Some of the current stents that we have now that can can enlarge much more than the actual size of the stent to start off with. So any of the stents, as long as you're comfortable with it and you're familiar with the stents. So culotte stenting, if it's the indication is for true bifurcation. Once again, the distal main vessel and the side branch have similar diameters. The advantage is that you can have a more homogeneous distribution of struts at the bifurcation. Obviously, there are some certain limitations or disadvantages. There's more steps that is required, especially in trying to wire the main vessel and side branch, and then you need to open the stent struts up. It can be technically demanding and time consuming, but in the end, it's going to be useful to know this technique. There's also concern that there's side branch stent malposition, especially when the proximal main vessel is much larger in terms of discrepancy, in terms of diameter. And at the same time, in the proximal main vessel at the level of carina, you expect that there's some excess in metal or stent struts in that area. So we have talked about this classical culotte, but one of the other advantage of a culotte is that you can have, or you can even consider a provisional culotte, in the sense that you are considering whether you need to stent the side branch or not to stent side branch. So in this case, the opposite goes, in the sense that you stent into the main vessel first, and then you assess the final results. And if you feel that you need to stent the side branch, then you can even consider a culotte in this case. So a provisional culotte by stenting the main vessel before the side branch. So to summarize, the culotte stenting, it is meant for true bifurcation lesion and where the distal main vessel and the side branch size are almost similar in diameter. And the angulation is fairly shallow, probably less than 70 degrees. And if you stent in the classical culotte, you should stent the angulated vessel first. And in most cases, this is the side branch. Remember, final kissing, balloon, and port are essential. And you can have imaging that would be ideal because you're aiming for a zero null opposition target. So thank you very much for the kind attention. Jack?
Thanks, Rosalie. Indeed, that was a very comprehensive lecture. I really like it a lot. But for the purpose of the fellow, can I invite now, just before I move on to the live case, Dr. Sydney Low, to maybe just provide a few other pointers for this particular session. All these points that Rosalie put up, what do you think are the most important barriers to cross for the fellows, the concept to understand, so that when we do the live case later, we can focus on those points? And maybe Fahim to also answer later whether stents make a difference, whether we need to know the stent characteristics. Is it that important for the current generation stent? Sydney, please.
Yeah, so I think it's number one of the key things about the anatomy is about, as you mentioned, is the size of the branch vessels. And they're very similar in the culotte because I think one is the understanding of how big you can dilate the stent strut. Now, there is another variation that you didn't mention very much, which is called the string culotte or the ultra mini culotte, where only a little bit hangs out into the main branch, and you try to catch that with your wire and then dilate that one out, and so you have a ring. Now, remember that the main problem with that is you have to understand how large you can dilate a strut to make sure that that vessel is not too large, so that now it's not going to be enough. So it's restraining the expansion of the main branch stent. It can be very flush on if you can do it well, and the string culotte can be done quite well if the vessel sizing is okay. The other thing is that in countries where you can afford it and you can do imaging, the teaching has always been, for example, in Korea, I suspect, is to do imaging from both branches into the main, particularly left main, to the ostium, and understand the distribution of plaque, which you've already mentioned, is mostly on the shoulders. And there's very little plaque, generally speaking, in the carina or flow divider. And so you need to make sure this is well covered. And then the culotte covers it very well. The question really in your mind is that what is the coverage if you do ultra mini culotte, or now there's another variation called double kissing culotte or DK culotte, which is better? I think that most of the time, when you do the post imaging from both branches, you can get a very good expansion, particularly if you do a good kiss and you do a good pot. The pot in the October trial, there's a problem with pot if you do it badly. So you lose the advantage of your kissing dilatation, and you can destroy kind of what the kissing does is the distribution equally around that bifurcation. So you have to understand that you have to leave enough length of the vessel. So it's difficult in short left mains because you might be actually encroaching on the carina or into one vessel, and you destroy the kissing dilatation advantage of the double non-compliant balloons. And so you need to understand the short balloon and how it does, and how to do the pot. And the pot is kind of essential to do well. Otherwise, you can destroy the kissing dilatation.
So, Sydney, if there's one point you want the fellows to learn in the live case, what is, in your mind, an important learning point for fellows?
Okay, I think Rosie's mentioned it. So in a classical culotte, control side branch, so do the more angulated vessel first.
Okay, good point. Dr. Fahim, what is one point you want the fellows to learn from the live case? You're muted, Fahim, sorry.
Sorry about that. So I think that, something that Rosalie already talked about, and Sydney too, that, you choose the right patient. So I've seen people do culottes with, a 2.0 or a 2.5 vessel, and approximately it's like almost a 4.0. And those are not the cases. With modern stents, you can sometimes get away with it because a lot of the stents now are able to expand a lot. But I think the mechanics of that is still just doesn't seem right. So I think, it's important to find, a bifurcation where the proximal vessel and the side branch are, within about 0.5 of each other and not more than that.
Excellent.
Don't put a culotte and a 2.0 side branch.
The right patient, almost similar size side branch and main branch. Dr. Joshua Win, what is your one learning point you want to drive home in this workshop for fellows?
the most important thing is assess the bifurcation angle and the ostium of the side branch. You know, for the Culotte technique, you know, the bifurcation angle should be shallow. Otherwise, you need to choose the other bifurcation intervention technique. Yeah.
So that point is a great one, but we'll debate that a bit later. So one point, this is about choosing the right patient. Remember our objective. So we got same size main and side, angulated branch first. Shallow angle is preferred. Dr. Fazila, what one point do you want the fellows to learn from this session?
Well, I think if you have the option, use imaging, because imaging in a double stent strategy will give you great immediate as well as long-term results.
So we'll share what we mean by imaging later and the points in imaging. Dr. Takashi, what is your one point you want the fellows to learn? You're muted. Yeah.
Okay, thank you. So the practice is different from each country. So in Japan, we use an IVUS or OCT, sometimes or FDI for almost all cases, especially for the bifurcation regions. So I think the most important point is the best result after the Culotte. So if you want to see the results, I think imaging is very important, especially left main bifurcation. So if possible, IVUS guided bifurcation PCI is the best option.
Okay, great point.
Can I ask Dr. Kajiya about one question? The question for the Japanese operator is it better to do single stent? Is that more preferred than the Culotte? I just ask.
Okay, so yes, now our practice is the single stent KVT was just single stent, just port is a first priority. But as Rossi already mentioned, that if you choose a provisional Culotte, you can choose a one stent KVT or two stent strategy. So it's good to know the Culotte technique. Culotte technique is a very basic two-stent strategy. So this seminar is very useful for young operators.
So we'll come back to Dr. Pham later because he's going to teach us on the IVUS lecture about how to optimize and we'll call for opinion there. So we sort of like got a rough gauge of the ideal patient, the things to watch out for, but it's not fully fleshed out yet. So we'll go to the live case now. So hopefully that will flesh out some of the points that's brought up. So can we share the case history for the live case briefly?
No?
Yep. So now you can share the case history.
Okay. Can you hear us?
Can you hear us, Jack?
Yeah, we can hear you loud and clear. You don't have
All right, great.
Okay, so welcome everybody. Nice to see everybody on the computer. It's honored to be invited here with Chiang to do a live demonstration here. So Chiang's going to present this case history. Yeah.
All right, okay. So thanks again for attending. So today we have a case on the table. He's 75-year-old. He's a man with a background history of diabetes, hypertension, but otherwise was previously quite fit and well. He just came in to us about 2 days ago. He came in with non-ST elevation MI. Echo showed EF of 42% with some regional wall motion abnormalities in the inferior territories. So we brought him into the lab yesterday for a diagnostic angiogram, and that showed that he had two vessel disease involving both the ostia of the LAD and circ, as well as distal left main stenosis. So I think you can see the angiograms at the moment. All right, so currently you have on the left-hand side the a cranial view. Now on the cranial view, you can see that the left main ostial LAD looks a bit hazy. In terms of diameter stenosis, doesn't look too bad, but it definitely looks hazy. On the spider view on the right-hand panel, the ostium of the circ looks probably tight, and there's also a further proximal to mid circumflex lesion as well. Show the next view. Now this is the AP caudal, and I think on the AP caudal you can very well appreciate that the distal left main is tight, about 70% tight, but definitely looks significant here on this view. So what we know for sure is that there's a lesion in the proximal circ. The ostium of the circ also looks tight, and the distal left main looks tight. Ostium of the LAD looks hazy, and geographically not very tight. So provisionally was Medina, 111 or 101. But nonetheless, yesterday the decision was to have a further discussion with him, give him the opportunity to consider bypass grafting as an option instead of left main PCI. So after some discussion yesterday with him and the family, he has opted to proceed with PCI, and that's why he's here today, just in time, if you like, for our demonstration. So that's the case.
Yeah, Sandeep, can we switch back to cath lab, please? Aaron,
Yes.
can you tell me what is the main learning point you want the fellows to learn with your demonstration?
I can't hear you very well, Jack. And can somebody up the volume a little bit?
So Jack was
the learning point of...
So in the Culotte, you're teaching fellows now, right? So what is the main learning point? You heard what the other faculty has said. What is the point you want to demonstrate or you want the fellows to bring home today?
Yeah, so I think the main difference between DK crush and Culotte is that if you have two vessels that need to be very important, that you need to keep the wire in, DK crush actually is a more preferred method because it won't lose any branch. So once you stand the branch, you crush it, that branch is patent and you can stand the other one. For Culotte, you may lose one branch, depends on how tight the ostium of the other branch is, because once you stent it, the other branch ostium may get compromised and you may have difficulties wiring that branch because of the ostium is pinched. Yeah. So for Culotte, I mean, if you have a side branch, both side branch, which is very critically narrow, then you have to be pretty careful because you may lose one of the branches. Yeah.
So great point. So you have to pull wire back. There's change out wire again for Culotte. So maybe Chiang, also for you, what is a learning point you want the fellows to bring home?
Yeah, so I think those are great points. Everyone's made good points. I think the other thing when it comes to left main, especially left main bifurcation PCI, is to really understand the lesion properly with intravascular imaging. And so today we will use intravascular imaging. I think that really helps to optimize your stent sizing and your final PCI results as well.
So I think we'll let you show us what you've done so far before I start asking the fellows in the gallery some questions, particularly my late coming Singapore fellows first.
Okay,
so maybe you'd like to share with us what you've done so far and your strategy for this case and why.
Okay, so this is the angiogram that you've seen. So the question is whether the LAD lesion is tight, but if it is, it's a borderline lesion in the oxide LAD. But if we want to stent the circ, I think the LAD ostium will probably get compromised. So even if it's borderline lesion, we already decided that we're going to do a two stents technique. So obviously we're going to do a Culotte in this session. So the choice between Culotte and DK crush is a lot depend on what Rosalie have mentioned, the size of the vessels and also the angle of these two branches. Yeah. So the size, these are both 3/0 vessels from angiographically. So it's more favorable for Culotte. The angle wise, actually in this case, I may have preferred a crush technique for this one because the angle is quite is about 90 degrees. So maybe it's better for a crush. But anyhow, I mean, for both techniques, it can be done.
Yeah.
So what we did is we want to just show you the actual Culotte stenting rather than doing the pre-dilatation and everything. So we've done some work. So we pre-dilated the circ lesion, and then and the ostium, the left main as well, in order for the IVUS to go down. So we just show you the IVUS in the circ. Actually, we skipped the IVUS of the circ because we just want to tell what's the size of the circumflex. It's about 3/0. Yeah, it's 3/0 vessels because we want to put a stent there first. Next. And then we do the LAD IVUS. So can we play the IVUS, please?
Yeah, show the second pullback.
Yeah. So it'll be interesting to see what the IVUS show for the osteo LAD. Yeah.
Yeah, so this is the pullback from the proximal LAD. It's now in the proximal LAD. So you see mostly fibrotic plaque. There's a little bit of calcium in the 9 o'clock region, but mostly fibrous. Coming to the ostium now of the LAD, you can see it starts to get tight just in the ostium of the LAD. So this is really a true bifurcation lesion, Medina 111. This is in the distal left main. The left main also has moderate amounts of plaque. All the way back to the ostium as well. That's in the aorta.
Yeah. So
can I take a pause here, Chi-Yang and Aaron? Can I ask Dr. Takashi, in Japan, what are you looking out for when you do this? Is it truly just vessel size, plaque distribution, like what Rossley was talking about? For the fellow, what is one learning point from IVUS pre-stenting?
Let's see, ask him to replay the IVUS. Just replay the IVUS.
Yeah, can we, OP-Van, can we go back to IVUS imaging and replay that? So can you tell me what for the fellow, what do you actually look for?
This is not.
Yeah, this is the
left main?
LED.
No.
Yeah, go back to the start of the pullback.
Start with the pullback. Yeah. I can't hear anything.
Yeah, it's okay. We'll just let it run. So Dr. Rossley, Sydney, and Fahim, anyone else who feel free to jump in for any pointers for the fellows, if you like.
On screen, right? Yeah.
So once again, Jack, looking at the plaque distributions, a lot of plaque around, very concentric around here. And you can see that very commonly the plaque is exactly what you expect in a bifurcation. It's straddled across the shoulders, and commonly osteo-LAD stenting is quite difficult to do because the plaque, particularly it extends from the left main across. So commonly you see a lot of left main stenting in Korea. That's because there's so much imaging has been done. And we know that there's a lot of plaque that extends across that shoulder. So you see here, you can't get away with not stenting the LAD because you can't get away with just stenting the ostium because the plaque extension, it's very much throughout the whole thing, all the way to the ostium of the left main. So there's also the other question about how much of the left main do you do? Is it okay to land in the middle if there's no disease? But the disease here is extensive. It goes all the way to the ostium. So you often will have to stent the left main, across to the LAD.
That's a great point, Sydney. Yeah. The rest of the faculty?
One of the things that is also seen is that as what we see in osteo lesions, they tend to have to be fibrotic and calcified as seen in this case. And that tells us that we must prepare the lesion very well. And the reason is this, because if you see with a two-stent strategy, the risk of coming back is usually at the ostium. So you need to ensure that you prepare the vessel very well, prepare the lesion very well, and then when you stent it and make sure that in the end you go back with a non-compliant balloon, and that extra work of getting the stent to be well expanded in ostium plays a big role in reducing the risk of restenosis in the future.
Sometimes on the longitudinal IVUS construction, you can see if you see a spiky carina, right? A spiky carina actually may suggest there's a higher risk of side branch restenosis, so potentially supporting the double stent strategy. So there's actually a called an eyebrow side.
So as Rossi already told, this bifurcation, the ostium LAD, we need to prepare well. So some cutting device or squaring balloon is a better option. And another point is this case, first stent should be stent from left main to LAD or circumflex. This tight region, this LAD ostium region, maybe it's better to stent from left main to LAD first, then second stent should go to circumflex. The Rossley's lecture, he said, more angulated vessel, we should stent first. But sometimes if we see a heavy plaque for main main vessel, maybe the first stent should be stented in main vessel. So maybe we should discuss which one first.
So before we discuss more among the faculty, I want to take a pause to ask the fellows in the gallery, is there any hesitancy for them in this case to employ a two-stent strategy? And what is their reservation as fellows? What's their worry when they embark on this type of case? We'll start with my fashionably late Dr. Sim Hui Wen from Singapore NUHS. Hui Wen, are you online?
Hello?
Yeah, Hui
Yes.
Wen, if you look at this case as a fellows in training, what is your main concern and what are the questions in your mind?
First, it's obviously a two-stent strategy. So the first concern I would have is, because actually can I see the angio image? I think it's quite tight.
A bit tough, you have to pay attention from just now. So
Okay.
what is your one concern? Then we can move on to the rest. Just tell me your one concern.
I think because both the main branch and the side branch are quite tight, so I'm just worrying. I just worry that if I stent the side branch, whether the other one will be jailed.
So you're afraid of losing the branches
Yes.
in the bifurcation stenting.
Yes.
Okay, Che Yang, what is your main concern as a fellow? Dr. Ku Che Yang. If you're not on, Dr. James Wang.
Yes, actually, I would be most concerned about losing the side branch, right? Because side branch is pretty tight, but there's also a distal left main lesion. So I think it's quite difficult to determine which one we will place more importance in the initial part of the strategy.
Yeah, so I think I hear a lot in this kind of workshop from the fellows is that they're not confident in preserving a main side branch, especially you need to switch wires back and forth in the Culotte technique. There's also a question here in the Q&A from a fellow, Hashru, about since this angulation is almost 90 degrees, isn't it better for a crush or a tap rather than a Culotte? So for this question, maybe I can get Dr. Fahim's comment. Will you have done a Culotte here or will you go with some form of crush or tap?
Yeah, I agree. I mean, I think that with that angulation, my preference would be to do a DK crush. It doesn't mean you cannot do Culotte, but it is probably, if you look at the stresses and strains on the stent with such an angulation, you may be better off doing a DK crush. However, as I said, it can be done, and I'm sure Aaron will show us in his usual expert style that how well it can be done.
Okay, great. So in the interest of time and the patient comfort, we're going to go back to Aaron, let Aaron finish off everything else on camera, step by step for us to see.
Can I just make one quick comment for the fellows? Yeah. I think, IVUS.
Obi-Van, can you switch to imaging first, cath lab, then while Fahim makes his comments?
So for the fellows, I mean, the IVUS took about a grand total of about 5 or 6 minutes. And in those 5 minutes, you figured out that the vessel size is big. You are looking at probably 3-5 at least in both branches. You figured out that there's not that much calcium, so you can do without rotablation. And you figured out that you need to extend the stent more proximally in the left main than you probably would have thought from the angiogram. So the IVUS has given some key pieces of information and with just about 5 or 6 minutes of an effort. So that's the beauty of imaging. It gives you information that you would otherwise have not gleaned from the angiogram.
So sorry, Aaron, so sorry to delay you. Are you unmuted? Can you tell us your step-by-step now? So I see you place a stent with what you felt was a more angulated branch, a circumflex, and you're about to stent the circumflex now. Can you share with us the size and of the stent now? Can you unmute Aaron?
So we're going to proceed. So what we did is we stent the SERP, mixed SERP, and then we plan to do the Culotte, stent the SERP first. I think in this case, I need to stent the SERP first because the SERP ostium is very tight. We dilated it, and it may cause some, it may have a dissection that may be difficult to cross. Yeah, so actually LED, you're right. The LED was very fibrotic and calcified, so there's balloons tripping. So we use a Scoreflex scoring balloon to dilate the LED ostium. So that's what you see. So now we're going to place the stent in a SERP now. So it's a 3015. Cynical. So the amount of stent that you lift in the left main, it depends as minimal as possible. Okay, we can push in a little bit more actually. Yeah, yeah. So we don't want to do a classic culotte that is too much stent struts overlapping. Yeah. Okay. Okay. One more time, Cynical. I think that should be fine. Yeah.
So Aaron, we're going to just watch you narrate through this piece, and then we'll critique your intervention later. Okay.
Okay. Come back a little bit. So we know that we're going to stand quite far back to the left main. So we're going to just do a high pressure balloon here. Yep. Careful the guide in, huh? Because there's still some trap wire here. Okay. 14. So we deploy the SERP stent. So you have to be careful when you pull back the balloon. The guide may jam in, may destroy the stent struts. Huh? Yeah. Yep. Okay. I'm pushing the guide. Yeah.
So sometimes I see Chi-Yang disengaging the guide a little bit before he pull back the balloon.
Okay.
So as not to have the balloon.
Now we're going to do a port. The IVUS show that is about 4045. So we're going to just go to the 40 port NC balloon. We use a shorter one because sometimes the stent inside the left main is short, so you don't want to injure the non-standard segment in the left main, and you also don't want to put the too big balloon in the side branch. So this is 408. So we can just go to dilate near the carina. So the stent that we use today is Ultimaster Tansei. As mentioned by Rosley, the big vessels usually you want to use a 2-link rather than more link. So this Tansei is 2-link stent. Okay.
How much can this Tansei 30 go up to, Aaron?
There are two platforms. 30 can go up to 4.5, and 3.5 can go to 5.5. Yeah, 12, 14. Yeah. So you actually went into the SERP a little bit. I think should be fine. Yeah, the tip. Yeah, take out.
So
okay. So at this point of the Culotte technique, there is a lot of variation. So some people will pull out the steel branch and wire the LED. So that's not advisable because you may lose the LED. Some people will pull back the SERP, in this case, to wire it, which most of the us will do. That's what recommended by Rosley. So if you want to keep both branch, sometimes people using a third wire. So what we do is going to pull back the SERP wire to wire the LED. So this will ensure that the wire is within the stent struts. Yeah. So Chiang going to pull it back near the.
You're on the quarter view now or frontal view? We're not seeing you live.
So we are wiring the LED now.
Yeah.
Yeah, the wire is a little bit damaged, so maybe a little bit difficult. So we try actually not to pull back before the stent, but sometimes it's unavoidable because it may inadvertently goes into under the stent straps. Yeah.
So this part, actually, Aaron, you have to address the fellows' fears, because as highlighted, there's a lot of fear in losing side branch, especially you have stented the more angulated branch here, which is a circumflex, like what Rosley and Sydney initially spoke about. But there's also concern that the main branch is actually left main into LED. So you have kept a trap wire, you pre-dilated the ostium with the LED, and now post-port, then you rewire back into the LED.
as you can see, the wire is sort of damaged a little bit, but Chiang still managed to wire the LED. So the question is, for this culotte, you have to wire the distal stent straps, yeah? But it's very difficult to decide which stent strap to go to, and the only way to find out is using OCT or sometimes stent boost to tell us where the stent actually goes to. The wire, which stent straps that the wire go through. So this is a little bit difficult because the wire is a bit damaged. So
yeah, don't worry. We want to see you struggle. Don't worry. It's okay.
It doesn't turn.
It doesn't turn. It went to a small branch. 要好了 ，OK， 我们再做了哈 ，OK。OK， 哎呦，
没那个裂。
Okay, let me have to.
Yeah.
So we may change to a new wire for facilitate wiring because we may have to wire this again later on.
So you might also want to give, I know it's a bit uncomfortable for a patient for a long procedure, maybe sedate the patient.
This is the side branch. We're going to park it there here. Okay, come. Can we have the 2O balloon? Come. Going to usually use a small balloon to open up first. We don't want to be too greedy, but experience is that with pop, this goes in should be very easily. Yeah. So after the 2O, we use a 3O to post dilate, to dilate, and then we use a stent, and we just stent it. Yeah. So we use the IVUS to measure the length from the diagonal to where we want to stent is about 26. So we might use a 28. Yeah. Same stent, which 3O, which will go up to 4.5 if needed, which is the size. As you see, it went in very, very easily. Yeah.
You also have an advantage of a trap wire there.
Yeah, correct. Yeah. So I usually don't take out the gel wire for now. Yeah. So
Aaron, just
I have the 3O, please.
Yeah. We'll watch you finish up the case first.
3O? No. We use a 3O NC balloon first. Yeah. So you can put the stent in now, but the thing is sometimes it's not well dilated, so the stent may get caught there. Yeah? So we're going to use a 3O NC balloon to open the stent straps. Open up, please, Charlie. Open up. The wire.
This is a new 3O.
So as you can see, Jack, in this case, the wire is wrapped. So the 3O balloon is not able to go in. So we're going to just take out the gel wire.
Okay.
You pulling?
Huh? You pull? I'm pulling, yeah? Pulling, okay. So I have to be careful. Okay, just plug it here. Come. So it should go in easily now, I hope. Not really. Yeah. Okay, yeah. Okay. So inflate 3O. 18. Okay, down. Okay, like Rosalie mentioned, nowadays they give me the 3028. Yeah. There is a I think it's CME, yeah, mentioned about double case culotte. The reason being, when we do this side open up the stent straps, the opposite end of the stent actually get pulled inside. So that will cause, when you rewire, it may go underneath the stent straps. Yeah. So, but I think in these big vessels, it is less likely. So in left main, I don't usually do a sort of double kiss culotte. Maybe in smaller branches, I may consider to do double kiss. Yeah. So this is a 3028. Yeah. Oh, back. So the wire is a little bit difficult to control. Yeah. Oh, careful. Okay. Okay, it went in smoothly. Okay, the wire go down. So we want to stand it just before the. Okay, yeah, just before the diagonal. Yeah, smooth test. Back a little bit. Just back a bit more. Back more. Okay, yeah, sini. Think too far back, I think. Maybe you can go in a little bit, yeah, just before the bifurcation. Okay, yeah, nice. Sini go. Okay. Inflating. Nominal. 9, 10, yeah. Yeah, expanded nicely here. Okay. So we try not to post-dilate using this balloon, although it's 3-0, but because they have disease in the left main, so we didn't cover the whole, the stent not going to cover the left main. So can we use the 4-0, please, now? So we need another port. Same one, yeah. And then after port, we will rewire the circ. Now, either you use a new wire, the other wire to wire it, or using this to wire. I think both are okay. If you use the LED wire, it probably pretty sure that it's within the stent struts again, yeah. But I think we're not going to use this wire.
Yeah, in this case.
It's already spoiled, so difficult to wire. Can we use the run through just now? Yeah. So I think for PCI, for the wire that we use, actually, yeah, go down a bit. Yeah. Just use a few wire that is familiar to you, that you use. So to know the property of the wire. So for side branch crossing, like in bifurcation, if you have difficulties crossing, maybe a hydrophilic wire may be easier to cross. Yeah, 14. Yeah. 要好了 ，Mr. Lee 哈，要好了哈，再给我10分钟就好了哈。Okay, can we do a stent boost? So if you have stent boost facilities in your lab, that would be good. Okay, here up. 14, 16. I think we have to come back a little bit more, huh? Just one.
Boost again, please.
Okay. Boost. Okay, 12 betul lah. 12. Okay. Open up, please. Okay, we do a cine now.
Save that, please.
Yeah, it looks like biplane, please come. Biplane. Okay, go. Okay. So it looks not too bad, yeah. So there is some haziness in the ostium of the circ. So that may be some calcium there. So I think after post-dilatation, hopefully it will look better. Where's the run through?
Here,
yeah, okay.
Talker, please.
Okay. Oh,
so Aaron, we're just going to watch Chiang wire close the carina and distal. Then we're going to switch to the wet lab to...
yeah, sure. So as you can see, the Chiang already crossed it already. So obviously, actually it's not... wait. Just see me here. I don't think it's a favorable position here.
Can you tell me why? Why not?
On the AP cranial view, it looks like very proximal. Can you see the angel?
AP cranial? Can you see me here? Oh, okay. So it looks like proximal crossing. Is that what you're saying?
Yeah. So we're going to try to rewire again. Yeah. Maybe, yeah, pull back and then maybe spider view better. Yeah. Spider view. Yeah. Okay, that looks okay. All right.
Any tips from Rossi about judging where is proximal, where is distal?
Oh, sorry.
Well, for me, Jack, it's always the angiographic images is so much clearer. So I tend to go to AP caudal or even the spider just to ensure that it's in. In the AP cranial view, sometimes you can't really see that well because it tends to be overlap with the LED stent. So I just based on angiographic assessment. Occasionally, when you have difficulty getting it indirect, you may actually try the reverse wire technique. There's a bit more curve, and hopefully it will catch on. And then from there, then you can wire, and it usually catches on the distal stent struts first.
Okay, from the fellows in the gallery, any questions at the moment? Anyone who wants to ask any question? Because we waited quite long. I think Aaron is trying to do the case in 5 minutes. But any questions so far?
Easily to the side branch, to the cert. I think that's the difference that pop actually makes, yeah? So 16, we have 3-0 again, come. We have 325, right? 325
Yes.
and 30, okay. Can we put 3-0 in the cert and 325 in the LED? We're going to case. Huh?
No.
Yeah, it's fine. Yeah.
So Jack, the demonstration was very good because notice the wiring was that you put a big bend on your wire, you pass the bifurcation, you pull back, and then you wire the distal when you have
LED
the
is the filter.
Yes, correct. So I think Aaron and Chiang is going to do the kissing now, followed by. Do you necessarily do a final port again for Culotte?
I think with this length of stent in the left main, yes, I'll do a port because I have the 8-0. But if the sorry, 8-0 no, 8 millimeter, 408, yeah. So I will do, but if the protrusion is less, I'll just do a case. Hopefully the balloon can. Yeah. So we are using the old balloon, inflated balloon. So, and the wire probably twisted a little bit, so it may be a bit difficult to go through, yeah?
So for the fellow's sake, when this happens, Dr. Joe or Dr. Fasila, how do you tell whether this is wire wrap or is it the stent is not well opposed? Is there any way to tell?
Well, what I think is that if you're having difficulty, you're not sure whether your wire has gone under the stent or it's in the lumen. One easy way is to take a very small balloon and see whether it goes down, right?
Yep.
That's one way of
do is wire wrap. You can just gently inflate the balloon to push the wire apart and then gently just push down. So that's what we did. It went down a little bit, but now the wire has lost position a little bit. So we're going to rewire it. Yeah, the third wire, please. Okay, now push down. Yeah. So we just do a gentle pressure here. Not too far down. Pistol, I did a little bit oversized. So 8, yeah. Okay, now before we do the thing, can we have the 3-0, please? Yeah, 3-0. Can I have another in deflate? Oh, it's fine. We just show the this. Use this one. Oh, I have another one. Okay. I'm holding tight. Negative for me, please. Negative, yeah. So most of the time we use 6 French, but when the balloon is a little bit big, so sometimes may have big difficulties.
That points to the guidance by Rosley about when you're starting out, it may be a good idea to start with a 7 French, especially in the left main location. It's easier to pass big, especially square balloons.
So the 3O balloon in now.
It's tight. It's tight.
It's very tight, but
Is this
okay,
a
coming in
new
now.
balloon or a square balloon?
It's a square. It's a used balloon. Yeah.
Yeah, you are.
You may want to take a new one. So sometimes.
Yeah.
Yeah. It's okay.
Oh,
Yeah.
got it. Got it.
We're trying to save some money. Yeah. Okay. Okay, it's fine. So, Spider, we haven't post-dilate the.
Fahim has some tricks to show later as well.
Okay.
I think Aaron's point about the balloons and the guide, I think it's very important to, when you're taking these larger balloons out and you've got multiple wires in the guide, to make sure your balloon is negative.
Jimmy, get back. So pull back a little bit or high pressure. So it's important to high pressure post dilatation here. Back a bit more.
Yep. The sugar.
Yeah, sir.
Yep.
Okay, yeah. I haven't come back yet. Anyway, it's fine. Okay, 20. Okay, now the LED. 18. Okay, so we're going to do a kiss. We have to make sure that it's overlap. Huh? Okay, because the LED balloon is a bit short. Huh? Okay, put LED come back a little bit more. Okay, yeah, come go up. 8. 8. Okay, come down together on 3. Huh? 1, 2, 3. So like Rosley mentioned that we have to go up and down, come down especially at the same time so that it doesn't create shift of carina. Huh? Okay. So we're going to do an angio, and then after this, an IVUS, and then we probably finish the procedures. Huh? Okay.
Okay, that's good. I'm going to let you finish up the case because I think the patient is a bit restless. So I'm going to show some guidance on the web lab first before I move on to the live demo for whatever you want to demonstrate by Ningyan. So I'm going to share this. Are you able to see this, guys?
Still negative.
So this is a demonstration by Dr. Takashi. So Obi-Wan, do you mind if you mute the cath lab? Just. So this is showing the port.
Stent tracks and side branch is widely open, and it is easier to rewire for side branch. If you do not report after main branch stenting, it is difficult to rewire for side branch.
Very soft.
To pass the guide wire under stent tracks. If you do proximal rewiring, followed by kissing ground inflation, it demonstrates stent tracks overhanging vertical line. It causes a potential risk of restenosis in the future. You should try distal rewiring after port.
Thanks for that, Dr. Takashi. Do you have any comments to those demonstrations on the web lab as well?
Okay, so in this demo, I want to emphasize just 2 points. One point is port, already discussed. So port doesn't mean just a proximal dilatation. Proximal, optimal, dilatation. So the first, the port, your balloon, the distal marker of your balloon should point at the carina, and you have to choose a appropriate size of port balloon. Then you can close your guide wire easily. This image is distal rewiring. Yeah, so this is a port, appropriate port. Okay. So after this is not port, so your wire cannot go into the proximal part of the stents. Even if you go the wire, but this position is not good. So
I just want to take a pause here and maybe emphasize that, Aaron plays a 3-0 stand in the left main. So this is probably, for the fellow's sake, this is probably what it looks like if you did not attend port and you were too anxious to get back into the side branch. The chances of the wire going under the sand strut or not getting properly into the vessel is very high. So any comments from the faculty on this part?
Well, I agree. I mean, I think for the part, as was just said, it's important that the inner margin of the distal marker should be just at the carina, because beyond the inner marker, the balloon tapers very rapidly, and so you need to make sure that the stent is precisely dilated at the carina, and so you have to make sure that the inner margin of the distal marker is right at the carina, as was demonstrated in this example, and that plays an important role.
So actually, Rosalie and Sydney also talked about proximal versus distal wiring. So this is a demonstration of what happens in proximal wiring. Can you really appreciate this on angiogram, actually, if it's not bench out? And does it really contribute to adverse outcome? What do you guys think, Rosalie and Sydney?
So I think that it's hard to know, because I don't think we systematically know where you've recrossed. We don't systematically do stent boost or clear stent to see the stent distortion. And you've seen on the bench, it looks much better if you distal rewire, because there's much better distribution and coverage of the ostium of the side branch, even if you do provisional. So I think that it's not necessarily correlated with clinical outcome, and we don't know. But I think that generally it does probably increase MACE events in the side branch because of the change in the flow dynamics and shear. The other thing is about the length for the pot. When you're sizing your length of stent, you have to make sure you have enough length proximally to do a pot with a balloon, so the balloon doesn't hang out about 8 or 10 millimeters.
Yeah, I share your views, Sydney, because I feel that one should try as much. One of the things I do if I'm not sure is that I take a cine. And once you take a cine, then you sort of magnify, and sometimes you can use a stent vessel vis, you see stent boost and inject contrast. You can actually see whether you got it in proximal or in distal stent struts. So some of the things that may actually help you, but yes, it's not you're not correct in all the times, but in the end, you have to make do with what you have and ensure that the stents are well expanded as much as possible before you kiss.
Okay, so this point always confuses fellow about wiring distal, wiring proximal. We can discuss a little bit more. I wanted to show you the bench model live as well, for you to appreciate what happens proximal distal. Just to bring it up in your mind, whether it translates the outcome or not, we think it does. There's no concrete proof, because it's very difficult to prove that it's actually proximal versus distal. I suspect those osteorestenosis is due to this, some of that, creating a false carina as well. So before we do, I want to show another tips and tricks as well for the next demonstration. Just now you saw that Aaron had problem crossing the side branch with a square balloon. So let's see a tip and trick.
Crossing a side branch stent using an anchor balloon support. Here we have a situation where we have a crushed side branch stent marked by the white arrow and a balloon marked by the red arrow that we're trying to cross with. We're not able to do so, and we place an anchor balloon in the main branch stent marked by the yellow arrow, and we're going to inflate this and use this to support the apparatus that allows crossing into the side branch. This technique can be used in any bifurcation technique, be it Culotte or DK crush. And as you see over here, the main branch balloon is now inflated. And now, with some effort, that previously uncrossable balloon is now able to make its way into the side branch stent, allowing you to complete the procedure.
So that's also quite a neat demonstration by Fahim, showing that if you have sometimes a problem crossing after you have positioned it, an anchoring balloon helps save some equipment rather than pull out a new balloon as well. Obi-Van, do you mind if you go back to Aaron and Chi-Yang and see where they are at now? We share the cath lab screen. So can we unmute Aaron and Chi-Yang?
So we IVUS the LAD looks acceptable, and we are trying to push down the IVUS to the SERC. It looks like it's not crossing.
Yeah,
maybe
so,
because of the angle.
Yeah,
because of the angle.
I wouldn't try too hard, Aaron.
Yeah, correct. Yeah. Okay, so I think we will just show you the take out. It's fine. Just show you the IVUS for the LED, and then we probably done here.
Do you have an angio to show us?
Yes, we have one for that.
We just look at the angio before the IVUS, please.
Yeah, so this is the angio.
Yeah, as usual, angio looks fantastic, Aaron.
Very nice.
Yeah. So play the IVUS from the LED to the left main.
So this part, maybe I'll ask Dr. Takashi, Sydney, and the rest, what are you actually looking out for post-application stenting IVUS? Chi-Yang comment first, sorry.
Yeah. All right.
Okay, can we start from beginning?
Yeah. So let's start the pullback from the beginning. So this is This is the mid LED distal to the stent edge. So on angio, it looked not too bad. On IVUS, as usual, we see a bit more plaque than we realize on angio.
This is diagonal. Yeah.
Yeah. So the distal stent edge will come up here. So distal stent, anytime post PCI, we want to know whether there are any stent edge complications. So that distal stent edge looked okay. The other things you want to look out for post PCI would be expansion, apposition. So how well the stent is expanded compared to the reference segments, and whether there are any struts hanging. So there was none of that. This is already in the left main. And you can see that there's still disease in the left main, obviously. But where we have landed, we haven't caused any trauma to the plaque, so there's no dissection. And it was all very well opposed throughout.
So I don't think we will IVUS the SERC because I think of the angle, the IVUS, the catheter not able to cross.
Can I ask, in Japan, right, since they do a lot of imaging for this, is it necessary to really make sure you have a final IVUS on both branches? Dr. Takashi?
Yes, if possible, yes. Yeah. But in this case, the angulation is very, it's difficult to pass this IVUS. You may try a Terumo IVUS. Maybe it passes easily to the this tight region or this angle. But in this case, apposition is good and expansion is also good. I think it's acceptable for this case.
Can I ask Dr. Fazila, if you don't have IVUS, would you have done anything differently, even without IVUS?
Yeah, for a double stent technique, it's always ideal to have an IVUS, and especially when you're doing a Culotte technique where you expect quite a bit of double metal mass in the proximal part of your main vessel. So if you don't have IVUS to make sure that your stent struts are properly opposed, what I would do is I would be absolutely sure that I do a proper job of port, because I have to make the struts properly opposed to the wall to get a good long-term result. So make a very good job of doing the proximal optimization, and also take good angio shots to see what my final result is, whether there is any dissection or any slow flow or any other thing that I have left behind that was not detected properly. Because as we have discussed, imaging really helps us in deciding these. So if I don't have imaging, I have to be extra cautious and extra sure that I do a great job before I say that I'm done.
Okay, Dr. Joe, you have any comments or teaching points from what Aaron did before we move on to questions from the fellows?
I do the same way as Dr. Fazila Malik, and I think if you don't have imaging IVUS or OCT, I think final recheck angiogram as much as possible to see anything, complications, and sometimes stent boost or stent base might be useful to see any stent expansion. So basically, I would do the same as Dr. Fazila Malik or support answer.
Thanks, Dr. Joe. Actually, one of our participants, not a fellow, Dr. Paul Ong, asked very good questions. Maybe I'll defer Paul Ong's question to someone else. He feels that proximal distal wire crossing has no difference since both ostium are completely covered by the stents. And also, he asked, is there any disadvantage in this type of case to stent right to the left main ostium? Do you find any difference in just covering to the left main ostium and therefore have more flexibility in the port and post dilatation? Rosley, is that your practice? If the left main is relatively normal, do you need to stent to the ostium necessarily?
I don't think so. I don't think it's necessary, but you just need to ensure that you've got enough length for the port, because you don't want to lend it to bit outside the stent struts. But in this case, I would have actually extended a bit more, because you can see that the area that it was landed, there was still some disease over there. I'll probably use it a bit longer in this case.
So Jack, in terms of imaging, so if you don't want to leave more than 50% plaque burden on either edge of a stent is correlated with increased events. So if you saw a lot of plaque left main, you may be forced to extend the stent to the ostium. So the imaging may push you one way. If you didn't see that much plaque there, so you probably don't have to. And I agree with Dr. Takashi about the, when you do post, you want to look at proximal distal stent edge for edge dissection. And commonly, if you dissect it, you put a second short stent there. And then, of course, you look at the stent apposition and stent expansion. And of course, you're aiming for, those numbers you've heard from Dr. Jang, 5, 6, 7, 8, and maybe a bit bigger in the left main in Excel, more than 10 millimeters or more in the left main. You want to get a good minimal stent area for reducing event rates long term. So, translatable from the trial.
Again, people keep emphasizing on imaging. So now we're going to move on to a lecture by Dr. Pham, just focusing on imaging, a quick 5, 10, 8 minutes lecture on imaging in left main bifurcation PCI. Jieming, you want to share your screen? Dr. Pham, are you okay to present? You're muted, I think.
Yeah, can you hear me, guys?
Yep. You want to share your screen?
Yes, I just shared it. Can you all see?
Yeah, okay, go ahead.
Okay, so thank you very much. Today I'll be talking about the use of IVUS in left main bifurcation. So some of the technical challenges operators face in left main stenting include the fact that distal bifurcation is often seen in up to 80% of the time. And sometimes there's a mismatch between the proximal main vessel and the distal side branch vessel size, requiring proximal optimization technique or port for short, as we talk about. So if you look at the right side of the diagram, we have Finette's law that depicts a relationship between the diameter of the left main and the LVD and circumflex. So ideally, the left main diameter should be 2/3 the sum of the LVD and circumflex. And it's important to perform port in this case as it's been shown to reduce malposition and elasticity and increases the proximal stent expansion. Now, the austere position of the main vessel also requires the use of a stent with a high radial strength, such as that of the Ultimaster or Tansei. And calcification is frequently encountered requiring more aggressive lesion preparation. And because the side branch tends to supply a large territory, in this case, for this live case, like the circumflex, the risk of hemodynamic compromise is high, requiring beyond stenting. So in order to overcome these technical challenges, optimal PCI is necessary to improve clinical events. And this will include the use of intracoronary imaging such as IVUS, the use of appropriate bifurcation technique, and optimal DES. Now, IVUS is now readily accepted as an adjunctive tool in PCI as seen in this case here. And according to the latest 2018 ESC guidelines on myocardial vascularization, IVUS is actually considered like a class 2A recommendation in selected patients to optimize stent implantation, to assess the severity of unprotected left main lesions, and to optimize treatment after stenting. This has actually been translated into clinical practice in some form. So here we have a slide that shows the results of an internet-based survey conducted among European and Japanese interventionists. So as seen here, among 1,100 responses to guide left main interventions and assess intermediate left main lesions, and to guide intervention in bifurcations, found some of the common indications. So as you can see here, IVUS allows the operators to obtain precise wall measurements and for us to understand the underlying plaque composition of a diseased vessel, some features which may not be so readily apparent on plain angiography. So rather than just using the naked eye visual assessment, IVUS derived minimal lumen area, as seen in the central part of the diagram, allow us to determine whether the left main lesion is significant or not. And if it lies within the gray zone of 4.5 to 6 mm square, one can consider the use of FFR. And using IVUS, we can also see or exclude whether there's any troublemakers in the listed landing zone. And this will help us to decide on the appropriate stent length and diameter. Now, it's also important to do 8 mm square for the left main and 6 mm square and 5 for the circumflex, respectively. So the clinical benefits of IVUS guided PCI was actually seen in Ultimate, a randomized control all-comers trial. That was published about 2 years ago. So among about 1,450 patients and almost 2,000 lesions, 9 to 10% of which were actually left main lesions and 25% were bifurcations. So the use of IVUS guided PCI was significantly associated with a lower target vessel failure rate compared to angiographic guided PCI as shown here. So among the criteria that was actually used by operators for optimal stent deployment was the use of a minimal lumen area in the stented segment of more than 5 mm square and no edge dissection involving the media with a length of more than 3 mm. And in this pooled analysis involving about 1,670 patients from 4 registries with left main lesions treated with DES, IVUS was actually associated with improved survival free of adverse events in 3 years. Yeah, shown here. So I just want to go through quickly 2 case examples that shows the use of IVUS. So the case 1, 73-year-old Malay lady with multiple risk factors and chronic renal impairment, admitted for NSTEMI with congestive cardiac failure, EF of 40%. And this is the angiogram that shows a Mandina 111 bifurcation lesion with TIMI1 flow down to LAD in fact. Now the RCA, there was actually just mild to moderate disease. So I elected to predilate both the LAD and circumflex first with a 2O balloon, as shown here. And I run the IVUS down. As you can see on the right-hand side of the screen, there is actually severe disease in the LAD, and actually moderate disease is circumflex and calcified left main as well. And in this case, I elected to do a double stent strategy because I was concerned about the disease in the osteocirc, higher chance of hemodynamic compromise and beyond stenting. And also in treating the side branch first, I used to the following landing zone criteria: reduce plaque burden and landing zone that have the largest lumen and no troublemakers. In addition, I would like to cover the bifurcation at least about 6 to 8. Okay, excuse me, it seems to be progressing on its own. So I'd like to cover the bifurcation at least 6 to 8 mm from the proximal stent edge to the bifurcation carina to enable subsequent port of a short balloon. So in this double stent strategy here, I deployed a 2.25 stent from the circumflex and with minimal protrusion in the left main. And after post-dieting the side branch stent, I actually crushed it. And of course, before I crushed it, I actually removed the wire and the stent balloon from the circumflex. Subsequently, I recrossed the circumflex and did the first kissing balloon dilatation. And next, I proceeded to do the left main and the LED. And this is me showing the landing zone for my mid-LED stent, which was a 2.5 DES, showing again a large lumen, smaller plaque burden, and no troublemakers such as calcified plaque. And just showing the end results here from the left main to the LED. All right, this was, I think, a 3.5 DES and a 2.5 DES. And I actually had to do a second recross into the circumflex at a port with a 4.0. And just showing the results in the IVUS, showing a reasonably good expansion and no edge dissection and minimal malposition. Now, my second case is a 55.
In the interest of time, we take a pause here.
Yep.
So that I can ask maybe the fellows in the galleries whether there's any clarification or questions at this moment. Anyone in the fellows have any questions to ask? There was some questions actually about putting a trap wire in the side branch. Any fear of the wire not coming out? Anyone has any experience of the wire being trapped that it doesn't come off? Rossley, any concerns?
I think in the left main, or if the proximal main vessel is quite large, then the risk is actually non-existent. Even if you go and port it, you will be able to come out. Or if you feel that there's a resistance and you find that it will not move and your guide goes in, then the other way of doing it is just to put in a balloon or microcatheter inside the wire which is trapped, go as close as possible to the site where the stent is. And the fact that now the site where your catheter is now, the microcatheter is now, or balloon is not very close to the site of the lesion and it's a small area, so you are able to then, by physics, plug with very little force. So I've not had an experience of jailed for a long time. As long as you know how you're dealing with, and you know that the proximal vessel is quite big, and you shouldn't be able or be concerned about jailing the wire or not able to pull down the wire.
It's a matter of risk, I think, and sometimes it can happen if there's a lot of long length of jail wire, if it's wrapped around. Two, if it's a lot of calcification and it's a very good center position, which you want, but basically you've entrapped the wire really well, and or you're restenting old stents. Maybe this metal on metal may increase the trapping of the wires. And Rosy mentioned using that trick of using the balloon on that trap wire. But if you're doing that, I would probably advise putting a balloon in the main part of the stent. In case you do have deformation of the stent, then you can actually inflate the stent up. Otherwise, you may find it very hard to go through again with a balloon in the main branch stent.
Again, excellent teaching points. Cath Lab, can we go back to the Cath Lab to see whether Aaron has any other conclusions for us? Before, I want to show you the live web lab and see what final point on the port, which I think is an important point to focus on, we can show before moving on. Because time is really running out, although it's been quite enjoyable. Can we go back to Aaron and Chiang? Obi-Wan, can we share Aaron and Chiang? If not, can we share the web lab, Sandeep or Yen-san?
Which one? Web lab or what?
And also, hello?
Oh, it's going back to them now. Okay.
Yeah, we can hear Aaron, but we can't really see you guys. And whether you can show the web lab model. Okay, so
seems to, yeah.
So Ning Yan, Actually, now you're wired without doing a port, right? Is that correct? So I want you to show the fellows what happens on the bench model if you have not done a port and you're wired through the side branch and you balloon through a non-ported vessel. So maybe you can show us the wiring again.
You can hear me, right?
Yeah, not very clear, but okay.
Okay, sure. So now we centered the so-called, the model into the live case, the circumflex into the left knee. So currently I have a balloon, it's a Paul balloon. Actually, I wanted to do a port, but
let's not do a port. Can you show what happens if you don't do a port? I think this again an important point to emphasize. Maybe you like to pull the side branch and try to wire into the other branch now. So oftentimes, I think even without doing a port, you can get a wire across. What you're not sure of, if you're not doing this maneuver and you're using another wire, is that the wire comes under the sand strut, which was demonstrated by Dr. Takashi earlier on. And in this case, I'll ask Ning Yan to dilate through this non-ported vessel and show you what it looks like, whether there's any issues.
Oh, is that me? I think you're muted. I think you're muted.
Chiang, you're not muted. Actually, we can hear you.
So I try using a 1.5.
So you can see this, firstly, if you don't port it, there is some problems with crossing, especially a square balloon across the sand strut. And you can potentially just destroy the stent. Can you push harder there to try to cross it?
Oh.
Okay, good.
Okay, what? 12, 24, 12, 14, 14, 16. Get down. Okay. 3.
So when you don't port, I think the observation to me is that the osseum of the circ shifts when you try to dilate the side branch. And then you may get some sand strut that's not well covered. Sometimes you wire underneath the sand struts. And any other comments, Dr. Takashi or Sydney and the rest of the faculty?
Yeah, can you hear me?
Yeah, Aaron.
Yeah. I think even after port, when you dilate the side branch, the opposite side of the stent still get pulled towards the carina. So the port actually is just dilate the main branch stent struts, but not to prevent the crossing, the pulling of the opposite end, the stents opposite the carina actually. Yeah. So that's why in Culotte, some people advocate a double kiss. So that double kiss can actually push that back. Yeah. But my question is that after you put the stent in, again you stretch that part, and that carina can the stent opposite carina can move again after the second stent. Yeah. So it may or may not make any difference, I think. Yeah.
The discussion point, Jack, is about stent crossover. So there's some suggestion the data, like for left main, is just stent over. There's not a lot of disease in the circumflex. That's because anytime you dilate through a stent, you have a lot of stent distortion. And you have to watch that very carefully, and you have to correct it. To truly correct the whole thing, you have to stent a balloon across the entire deformed segment, deformated stent, and to correct it, which means basically across the whole bifurcation. Yeah, so it's a stent crossover kind of balloon. And so, and then you have to correct it. So if you balloon the side branch, you have to then correct the stent distortion. That's one of those things we have to make sure we do. That's what Darren is saying.
Balloon down, balloon down.
Yeah. So as what Sydney talked about, you can see there's a lot of stent distortion every time you go up on the other anchored branch.
So the pot is really designed for optimizing the proximal stent. So the stent distortion tends to occur just a bit distal on the opposite side when you dilate through the stent strut. So that can only be corrected if you balloon passes over that point to correct it. And so you can see that sometimes very obviously on your X-ray when you're looking at it. So you've got to be very careful with that when you have a very big balloon across there, particularly if it's large. And you're right, the double kissing or the kissing balloon corrects it somewhat, but you have to be very careful about where you can destroy the pot. If the pot balloon is very far in to one of the branches, you cause the same problem. Yeah.
Rosalie, do you do a double kissing culotte?
Yes, Jack. I prefer double kissing culotte, and I find that subsequently the wiring and also the balloon crosses so much easier. So if I do a culotte, nowadays I usually do a double kissing culotte.
Okay. Then regards to Paul's point, do you guys think that there is a factual difference in proximal and distal wiring? Again,
Jack, definitely there is a difference between proximal and distal. If you wire the proximal, you create a carina in between the bifurcation area. So obviously we need to try to get a distal one, but the thing is on angiogram is very difficult unless you can see the bifurcation very well. The only way to tell is using maybe IVUS or OCT to help you guide it. Yeah, but sometimes stent boost like just now angiogram on the angio can tell sort of roughly, but definitively I think OCT is probably the best. Yeah.
Jack, I personally like the ultra mini culotte, so I do a lot of that. So I tend to not need to do DK culotte.
Actually, Sydney, the way you can do a modified string technique is to put the stent down using a Zabo technique. I mean, you are pretty sure that the wire is inside the last struts of the stent.
I don't have a problem. I don't like the Zabo.
Yeah, the thing is
it's a bit dangerous. The Zabo is a bit dangerous for stent embolization.
Yeah, you're not sure whether you wire the stent struts or not. How do you show that for this string technique, you actually wire the last stent struts? Sometimes you miss it and you create a converter in crush.
True. You may have a little bit hanging out, but you can't necessarily, if you don't do Zabo, you can't necessarily be sure you're in the last stent strut.
Correct, yeah.
Yeah, you're absolutely correct, but only a little bit is okay.
Yeah, Fahim, you want to say something?
I think, Aaron, if Sydney, if you're going to do double kissing culotte and all those kind of things, and in other words, adding to the steps, I think a DK crush is a much better technique that way. And there's randomized data that, at least in experienced hands in randomized trials, the outcomes are better with DK crush versus culotte. So I think if you're going to do something that adds more steps, probably a better approach is just to go straight and do a DK crush. That's what my preference.
That's also a way to think about it. I just want to highlight maybe on a pictorial diagram, if you can see the screen now, on this schematic I just drew, and to just explain what you mean by proximal and distal wiring for Fellows stick. So you have what Aaron did, right? Present a stent in the left main to the more angulated branch, as suggested by Rosalie. So now if you put a wire, you've done a port, and the port is important because it opens up the stent strut a bit more here. And if you can see, my wire comes, and when you mean proximal or distal, it may be easier to think about the carina. So this is the carina we're talking about. And when you talk about proximal or distal, it just means that in culotte, you want to wire close to the carina rather than away from the carina. If you wire away from the carina and you do a balloon dilatation, what happens is that you shift all the stent struts here, and you create a false carina by shifting the stent strut, which is demonstrated on the wet lab just now. If you wire distally closer to the carina, as labeled, then when the balloon comes out, the stent strut is shifted in the opposite wall, and the entrance is large, and you don't have a false carina. So it's a simple way of thinking about proximal wire crossing, and you put another layer of stents here. So as you can see, this is truly culotte, 2 more layers of stents, double layer. If you do wire again, proximal means away from the carina. Then when you dilate the balloon here, you're going to shift again stent strut to create a false carina. So you're trying as best as possible to wire distal and close to the carina. I mean, this is theory. You saw it on the wet lab that that Dr. Takashi demonstrated. If you don't, you create a false carina. But again, factually, it's quite difficult to appreciate without doing any form of imaging.
So Jack,
yeah,
Jack, that was very good, and I think that we probably should refer to it as the carina rewire because it's probably easier to understand proximal and distal. It gets confusing for everybody.
Yeah, yeah. I think.
And the other thing is that when you do stent boost and you do a provisional, if you do a KISS, you can sometimes on the stent boost or clear stent definitely see better coverage on the proximal part with the stent strap being elevated from the kissing balloon dilatation. And that's a very nice picture usually. And you can see that there's a lot more coverage from the stent strap being pushed on that side. So it looks really nice.
So a stent boost when the wire cross is a helpful technique, provided you get a good orthogonal view to make sure you're not misinterpreting the proximal and distal wire crossing. Thinking about distal wire crossing as closer to carina is also a good way in culotte stenting and thinking about where the wire should cross on fluoroscopy. On imaging, I must say I'm not so experienced in trying to decipher whether the wire is crossed proximally or distally on imaging, except we have a 3D reconstruction on OCT. So I think, the fellows in the gallery has been a bit quiet. Do you think I can ask some questions from the fellows? Whether you guys have any questions? Any questions from the call-in fellows?
Jack, sometimes it's about what you think you ought to be doing, the most ideal versus what you can achieve. So I think that they should not be demoralized. If you can get a wire in and balloon it, you might be left with it. Maybe it doesn't translate into a nasty event. They may want to prolong the DAPT and just be more careful with the DAPT afterwards. But sometimes you just you struggle. And wherever you cross is where you cross. You may try it again, but maybe you can't achieve it. So I wouldn't get demoralized with it. It might make it better.
Yeah, I think I agree with Sydney because sometimes beggar cannot choose. So sometimes, if you can cross, is very happy already. So yeah, I mean, angiographically is really difficult to see. I usually do a stent boost before I took out the last balloon to check how the stent structure look like. But if it doesn't look good, then it's too late anyway. So. Yeah.
I think it's also for the fellows important to remember that in DK crush, you're trying to cross proximally. So it's not distal.
Across the middle.
Yeah, ideally the middle, but if you can get proximal, but certainly not the distal. And for DK crush, it's a completely different paradigm. So they have to sort of remember what technique they're using and then where they need to cross, at least theoretically.
Yeah, DK crush is the opposite, so it's confusing. Okay.
Jack, before I can, before you end, I just 2 points, Disney. Number one is about the intertwining of wires. So just control your wire. I see that a lot of people are using sometimes their nails and to be able to cross, but in doing so, you might actually twirl it too much. I tend to use a talker, especially when you're going to use a two-stent strategy and limit the amount of twisting of the wire. So that's one point. One of the things I think this is because fellows course, I would still suggest for you to go for classical rather than a mini culotte or ultra like culotte, because you might just miss and by calculation and you will not get a culotte and you probably might even end with a kissing crush if the stent is not adequately positioned in the proximal. So be comfortable first and then subsequently you can be a Sydney load.
So I'm just going to go and in the last 10 minutes round the table to just give your teaching point again that you want the fellows to take back at the end of this course, starting from Dr. Takashi. Tell us a little bit about your teaching point to fellows after this culotte session.
Okay, so my point is just two, port and distal rewiring. But as discussed already, the distal rewiring is not always successful. But port, everyone can do port, right? Everyone can do the appropriate port. So I think the port is all fellows have to know the port and possibly distal rewiring. That's two.
Excellent. Dr. Fazila?
Yeah, so what I felt that there was quite a talk about twisting of the wires. So since it's a fellows course, I would think that the fellows need to, take a deep breath and do one step at a time. So whatever you're doing, do it to the best of your effort. And about the twisting of the wires, what I find very useful is using a sterile napkin to place between two wires and not to touch my wires and to be gentle with them as possible. So that sort of lowers the incidence of twisting, and do a proper job of proximal optimization. And if I do a proper job of proximal optimization, I think my wire will go to the strut that it needs to go. And if I am having difficulty with that, microcatheters sometimes help us. So we go with a microcatheter, and if I need, I can change the tip of my wire subsequently to help it go where I want it to go.
Thank you. Dr. Jaw?
Yeah, my point is, when you start this Culotte technique, you need to choose the right patient, and then be gentle as possible as whenever you cross the wire, as well as you take out the wire, to avoid the wire passing under the stent strut, as well as the difficult to retake out the wire. So gentleness is the most important thing, and then the port, the proximal optimization is the most important thing, is the bifurcation technique. Thank you.
Sydney?
Look, I think I agree with all those things, particularly need to prepare the lesion well, advise imaging if you can, and of course, NC balloons in both branches, and yeah, as precise as possible. I think that's one of those things I would like. So imaging helps that. And understanding the technique and that you can bail out from a provisional, I think that's great.
Rosalie, do you want to summarize the technique? Then we can just do down take-home message right at the end.
Right. Well, summarize. Well, the technique is fairly clear. I think what is important is for you to go through the steps in your mind and be very clear of one to the other, so that once you're very clear of the steps, then you would not falter that much during the actual procedure. Wiring both vessels, vessel preparation, and it has to be an adequate and appropriate vessel or lesion preparation, and then stent into one of the branches, and most times are not, for the classical culotte, into the angulated side branch. Remember to recross the stent struts. Before recrossing, of course, you need to pot, recross the stent struts, open the stent strut up, and then place in the stent in the main vessel, and then subsequently recrossing into the side branch, open up stent struts, and a kissing in two-stage procedure. The final kissing, well, before the final kissing, you have to make sure that ideally you go with a non-compliant balloon, high pressure, making sure that the stents are well expanded, and then end with the kissing at a fairly nominal pressure. And then a final pot if that is required. With imaging as an ideal way of ensuring that you get good results. So I believe that go through the procedure, choose the right patients, and just do it. Jack?
Yeah, can you hear me? Are you able to hear me?
Yep.
So I like the just do it part. I just do a quick summary, then I think we should close. Yeah, just checking that you can hear me correctly. Okay. So I think thanks everyone for participating in this session. I just want to highlight the fact that here we are addressing our fellows. So I just want to make it clear cut. I think first off, choosing the right patient, like what Dr. Joy and all this has emphasized, is very, very important. The right patient in this case means the patient shouldn't be, the first case is a high risk case. Doing a left main PCI is not what you're trying to do. Get someone senior to proctor you to do it properly, so that the techniques is well refined. Don't compromise on the guider. If you get a complex case, just go on the bigger guider. Don't try to do something tricky here. Imaging is important. If you can use imaging and use imaging properly, try to use imaging. if for all bifurcation, you can just do simple provisional stenting. I would advise provisional stenting has the best outcome here. If you do have to end up with a 2-stent strategy, decide carefully what is your comfort zone. I think in this case, it could have been done in a number of ways. The important point is port. And then once you use a 2-stent strategy, decide for yourself and be very clear in mind whether it's a proximal or distal wiring based on the technique they're using, whether it's a reverse culotte. And therefore, I think the confusion comes to fellow with the discomfort about securing side branch, whether it's a proximal or distal wiring. And I think in bifurcation, again, with a good port, you can be more sure with even fluoroscopy guidance of a distal or mid wiring closer to carina, expand out properly before 2 stents, final kissing, and a final port. IVUS helps in landmarking the length of all the stents that you use, the sizing, and ultimately the end result. As you can see, it's not 100% necessary, and sometimes it can cause more harm if it's not crossing properly, like in this case. So I'd like to thank everyone for participating in this workshop, and I would like to welcome you guys to join again if you are keen. I was supposed to have invited Rosalie to do it tomorrow, but tomorrow is polling day in Singapore, so it happens to be today. And we were supposed to do DK crush in the morning and Culotte in the afternoon. So now we have to break it apart in 2. Next month, we're going to do a DK crush fellows workshop like this, clarifying the difference between DK crush and Culotte next month. And I hope you guys can join us again. So with that, I'd like to thank all the participants, all the dialed-in fellows. Thank you for your time and patience for letting us do this on the first round basis. I'd like to thank my faculty and of course my patient and staff for contributing to this workshop. So I hope you have benefited, and please feel free to submit your feedback. Good and bad is welcome. So thank you very much for dialing in, and goodbye.
Thank you.
Thank you.
Thank you.
Guys.
Thank you.
Thank you.
Thanks, Jack. Well done. See you all.
Thank you.
Bye-bye.
Bye.
Thanks everyone. Bye-bye.
Thank you, everyone. Thank you. Bye-bye.
Bye.
Bye.